Hello, everyone. Or should I say bonjour and welcome. We are recording from not Paris. We're recording from our respective basements. No, but welcome to the second part of our rapid-fire tour through the highlights of ESMO 2022. So, our last time around, our last time around, I led you guys through a rapid-fire tour of some of the highlights of lung cancer, and Josh focused on breast and upper GI. So, continuing with the theme, Josh is going to lead us off with colorectal, of which there was quite a bit to talk on at this ESMO. Quite a lot of interesting stuff, actually. And I will close us out with some GU and some skin cancer shenanigans. But Josh, tell me, what was the most interesting thing you found in your journey through the ESMO abstracts this time around?
I think the fact that they actually had some colorectal updates, it was really nice. A lot of the time, poor colorectal and upper GI get left behind in the investigation spheres, and there's a couple of interesting studies, some utilizing immunotherapy, some utilizing targeted therapy that actually have some promising results. So I'll be interested to see after our discussion what you think, Michael, and whether you think this could become potential future standards of care.
I'm sure you'll have at least one standard of care for us after
Hopefully.
Your foray into the FGFR2 stuff last time and calling it standard of care right off the bat.
Yeah, so it's actually, speaking of the FGFR2, and I did know this, and I should have mentioned it last time, we actually had this trial open at my hospital, the Relay 4008, but there's some interesting points about that it's a selective FGFR2 and not a pan FGFR2, or potentially the other way around, and there's a race to the finish line with the FGFR stuff, and I don't know who's going to win it.
I'm sure the PBS is looking with bated breath for the winner, because they'll probably only approve the winner. There's no need to improve the company that comes in second.
I think it also depends on the outcomes, though, and the price.
That is also a very good point. All right, Josh, why don't you take it away and tell us all about colorectal at ESMO 2022?
Let the games begin. So
you don't want me doing my Bane impression this time. I already did French last time. You don't want me to do Tom Hardy as Bane.
Well, you have to keep some things fresh for our future episodes, Michael. Otherwise,
Absolutely.
I don't know all your repertoire.
Absolutely. So in the future episode where I do Bane, we can point to this particular instance and everyone can blame Josh.
Everyone already does. I won't bore people any longer. I'm going to be talking about the CAIRO5 study. Interesting. This is a Dutch study. I don't see many really big Dutch studies, but this is awesome. It's FOLFOX versus FOLFIRI plus either bevacizumab or panitumumab in patients with initially unresectable colorectal liver metastases and left-sided BRAF wild-type tumours. It's a phase 3 study. Important things to note: studies in colorectal cancer, generally, there's not that many. They don't always involve chemotherapy, so it's nice to see that, and it's nice to actually look at sort of head-to-heads of two VEGF inhibitors, right? Because that's exactly what they are, Michael. I think the interesting thing with bevacizumab is it's quite controversial here in Australia, whereas panitumumab is much more, it's not controversial. I think the benefits of bevacizumab are, some people are very much pro, some people are very much against, but we can talk about that at the end.
Should we call it debatable?
Debatable. That's the better word. Okay. So what's the background? So patients with, I'm going to say potentially resectable or initially unresectable liver mets may qualify for curative intent local therapy after downsizing by induction systemic therapy. So CAIRO5 was designed to find the optimal induction regimen. Here we present the results of this study. So they were randomized, as I said, to either chemo arm and plus either bevacizumab, which is arm A, or panitumumab arm B for 12 cycles. I'm going to refer to it as that. They were not allowed to have prior systemic therapy or local therapy for metastases. and they had a baseline scan, and then they were reassessed every 2 months. So think of it this way: 12 cycles every 2 weeks with this chemotherapy. That's going to be 6 months of chemotherapy treatment, so at least 3 reviews. The patients were then stratified whether they were potentially resectable or permanently unresectable, their serum LDH, and their choice of irinotecan versus oxaliplatin. Primary endpoint being progression-free survival. What I found is that the median follow-up was about 44 months. Age was pretty good, about the age of 60 in both. It was very well balanced, at least from the stats that I saw. I think it was 60% were male. Synchronous liver cancers were in 88 or 92% of each arm. And I think 4 and 3% had prior adjuvant chemotherapy. So a pretty small amount had gone to metastasize. The thing that I note is that with the outcomes, there were only 197 events. So their pre-specified aim when I was reading through this was 256. Couldn't understand why they didn't reach that, but that's just something to flag. Anyway, the median PFS in Arm A versus Arm B was 10.6 versus 10.3 months, with a hazard ratio of 1.12. So it wasn't statistically significant. What we did see, though, was an increased response rate in the panitumumab arm, which was 52 versus 76%, but the median duration of response was 33 versus 49%, also favoring panitumumab. And grade 3 toxicities was higher in the panitumumab arm. But in saying that, for the endpoint, which was progression-free survival and what we were looking at, there actually isn't a difference between bevacizumab and panitumumab. In looking at that, toxicities are higher in the pani arm, along with the fact that the duration of response was also better in the panitumumab arm. Greater than grade 3 toxicities was seen in just about 70% of panitumumab and 52% of bevacizumab. So fair few toxicities.
I mean, panitumumab as an EGFR inhibitor is significantly more toxic, sort of,
definitely,
than bevacizumab. But it's interesting that I guess how would you marry up the improvement in overall response rate and sort of duration of response with panitumumab with the fact that there was still no PFS benefit? Is it just like they responded initially and then, or they were more likely to respond initially, I should say, and then they just sort of progressed at the same time?
It's a really good question, and they didn't allude to that at all. But it'd be interesting to see, because my question is this: if the duration of response was better, does that mean, or, the response rate was technically better in the panitumumab arm, although PFS wasn't any different, could you operate earlier on these patients in the panitumumab arm if you've got an extra 20% that have responded? It doesn't make a huge amount of sense. And Michael, maybe correct me if you're seeing this very clearly, but I'd always assume that if you've got a better response rate, then realistically that would probably confer to potentially a better progression-free survival.
What doesn't really make sense to me is it's the duration of response is, you said, was better in the panitumumab arm compared to the bevacizumab arm. And so if you have a greater duration of response, you would think that the flip side of that is that you progress later, but I'm not really sure. But basically one of the I think the takeaways, like you said, this was for query resectable patients or patients who are potentially resectable. Is that right?
That is correct. So they're, I guess, borderline resectable. But in my institution, yours might be the same. If they're young, you're not going to use FOLFOX or FOLFIRI. You're going to use FOLFOXIRI. If I was redesigning the study, I'd like to look at, the really hard-hitting chemo and see how the outcomes were.
I think and I'm sure there will be people out there who will probably correct me on this, but I think the evidence, like the theory behind giving someone FOLFOXIRI, as it is in colorectal cancer, is to try and make an unresectable oligometastatic cancer resectable, is a good one, but I'm not sure that there's much evidence actually behind that. Because the one trial that I do know in this space is uses FOLFOX, but critically, I think with both of our institutions, you don't use biologics, you don't use bevacizumab, you don't use panitumumab. So From my perspective, it would have been interesting to see if the Bev or the panitumumab maybe have a third arm in there that was just Folfox or was just Folfoxiri, and see if the addition of the biologic actually gains anything, because we know that the benefit theoretically is relatively modest in the metastatic setting, but does it actually convert people from unresectable to resectable?
I think the issue with your study design alteration, Michael, is that depending who's funding the study, and if you're going against standard of care, which is just chemotherapy, and it's the same, it does some pretty terrible things to their ability to use this drug in this context.
You are a man of the corporate world, Josh. You understand they're thinking much more than I do.
Well, it all comes back to even just using chemotherapy as, unless you want to prove that it's better than chemotherapy, then you'll use it as the arm. But I'm assuming they probably aren't sure. That's my hypothesis.
Which these results would potentially bear out if there's no benefit to adding a biologic compared to each other. There very well may not be a benefit to adding a biologic at all.
Well, that's the thing, because I know with the patients I've treated, there's also that question about healing and delayed healing in the use of bevacizumab. It's a
huge issue with bevacizumab.
Yeah, so I'm like, would you even want to have bev if you're borderline resectable? I think the surgeons might have a different take on that.
Yeah, I think they definitely would. And in the instances that there's one instance of this that I've seen where a patient was initially assessed as unresectable. They actually went and sought a second opinion from a different surgeon, and the surgeon said, "Yeah, look, I'll give it a shot." But they had already received bevacizumab, so it was a huge undertaking, and there was a lot of bated breath around the time of the surgery, which unfortunately proved to be unsuccessful, about the consequences of bev and how long it was in the system and all that sort of stuff. So completely agree with your point that bevacizumab presents a minefield, and a potentially unnecessary minefield if you are looking at intervening surgically.
100%, and I need to correct myself, and we don't have to edit this out, but panitumumab is an endothelial growth factor receptor, guys. I think I said that both VEGFs, so just if you different, they work on different receptors.
Address all of your complaints about the inaccuracy of this podcast to Josh.
Yes, please, thumbs up and subscribe if you like, Michael, and if you don't, you can run away.
Let us know in the chat. Isn't that what they're saying on streaming things these days?
Something like that. Let's move on, just given time, and we have a lot of articles to get to. I'm going to talk about MOUNTAINEER, which, looking through all the data, it's actually previously been presented at ESMO in, I think, 2019 and 2020. So background to this study, we're looking at HER2 positive colorectal cancers. They really want some of these targeted agents to work in colorectal because it's been so successful with breasts. Although what we do know is that it doesn't really influence the prognosis of colorectal cancer. It's about 3 to 5%. But this study was evaluating the efficacy and safety of using two agents, one which was being tucatinib, along with the HER2 heavyweight, trastuzumab. These patients all had to be RAS wild type and HER2 positive. And from memory, they could have been previously treated for metastatic disease. Now, at least 3/4 of patients had at least 2 prior lines of therapy. And remember, in colorectal cancer, standard, there's about 4 lines of therapy, and then you're kind of looking at the trials and re-challenging. Now, the study design, multi-center, phase 2, 86 patients, 31 patients with single agent tucatinib out of the 80. So at the study entry, 64% of patients had liver mets and 70% had lung metastases. And each had a median of 3 prior lines of therapy, so they were getting towards the end. And approximately 85% of patients had tumor in the left side of the colon or rectum. The endpoint for this study, so that's what we want to know, was confirmed objective response rate, which is the outcome, right? So outcomes for this: median follow-up 20.7 months. It's a decent follow-up. Objective response rate 38.1%. That's in the intervention arm, and disease control rate of 71.4%. Median responsive time was about 12.4 months, and monotherapy treatment response rate was a measly 3%. Disease-free survival was 8.2 months, and median overall survival in the intervention arm was 24 months. That's not bad for colorectal, guys. At 12 months, 34% had received the intervention arm were free of disease progression, and 72% were alive. And at 24 months, 51% were alive. And when you look at tucatinib monotherapy, the response rate at 12 weeks was 3%, and the disease control rate was about 80%. But we need more lines of therapy in metastatic colorectal cancer. And looking at this, it's potentially a good line of therapy that might actually be a practice-changing option in the HER2 setting. I'm saying might because it's a smaller study and it's a phase 2. The other things is also like, where should we actually use this treatment? Should we use it after, FOLFOX, FOLFIRI, whatever other lines you want to use? You've gone to Lonsurf, which people struggle with, or, regorafenib, also not particularly well tolerated. And then you use this, or would you use this in, let's say, the second line setting, or maybe the first line setting? I'm not sure, and I think that should be investigated, given that it actually has a pretty good response rate. And it'd also be interesting to look at the toxicities, compare them to standard therapy. But yeah, and the only other thing to talk about is what is tucatinib. Sorry, Michael, I forgot to mention that. It is an oral tyrosine kinase inhibitor that's highly selective for HER2.
I think this also emphasizes, I guess, the importance of thinking of targets that we don't usually associate with certain tumor types. HER2 is becoming huge, and HER3 as well is becoming a significant target in not just breast cancer, where it's ubiquitous, it's very well known, even lay people know the name Herceptin. But, people are looking at it in lung cancer, in colorectal cancer. There's fairly established evidence in esophagogastric cancers. So, but it does emphasize that when you have patients who are getting past the first and second, third lines of therapy, to think about these less associated targets, because they're, even in Australia, I say even in Australia, but sometimes these things are a bit slow coming to our shores, so shall we say, Josh?
Sometimes,
but there are ways to request HER2 testing for patients with colorectal cancer and lung cancer, and it is important when you're trying to explore options, because it is probably more common than we think. I did have one question though, Josh, about the data, and you might not have it there. Did they talk about brain mets or CNS disease at all in the info you've got?
That's a really good question. Let me just have a look.
The reason I ask is because the only other study I've seen tucatinib in, again, in the breast cancer space, is HER2 Climb. And as a heavily pre-treated drug, it was all right. But what they really, really found that surprised, I think, everybody was that it was highly efficacious in the treatment of CNS disease, of brain mets. Now, brain mets aren't as big a factor in colorectal cancer. I think I've seen only one patient with colorectal cancer who had brain mets. But the efficacy of tucatinib is something that potentially opens a lot of doors for patients with heavily pretreated disease and brain mets, which are notoriously hard to treat. So I'm just wondering if that was applicable to this study.
Look, I didn't see it in what I was reading. Well, that doesn't mean it wasn't there. There was another thing I wanted to highlight. As I said, monotherapy treatment response rate was 3%, but that the control rate from that at 12 weeks was 80%. And I looked at it and I'm like, this just seems a little bit odd, this number. I would be interested to see when the actual trial gets published, to at least the updated data gets published, to see whether or not maybe I just read a typo, but it seems strange that you've got a treatment response of 3%, but disease control of 80%.
Maybe it was 80% of the 3%.
Who knows? But yeah, look, this is with people with multiple lines of therapy. They had a durable response. This is some exciting news for this cohort of patients.
Absolutely.
All right, let's move on to niche 2. Neoadjuvant ipi-nivo in colorectal cancer. There's a theme because there was another one at ASCO for rectal cancer. I think you probably remember it, Michael, and there was a standing ovation. And then every second patient asked me about this particular drug, and I'm like, this is not applicable to your cancer. So the background is neoadjuvant immunotherapy, promising in multiple lines of cancer, for colon cancer niche, which was the first study. I think it was the first neoadjuvant immunotherapy study showing pathological responses in 100% of deficiency MMR tumors. So for our listeners, DMMR or MSI high are the kind of the cohort of colorectal patients that will respond to immunotherapy. There's a lot more work that needs to go into that sphere about, yes, we know that, but not everyone responds, but it's essentially a marker. It's not like PD-L1 where you know if you've got a 90% response rate, then you're likely to have a really good response. It's a little bit more nuanced than that. So what they did know in this particular trial, importantly, disease-free survival in patients with stage 3 DMMR colorectal cancer was similar to that of PMMR. And the 3-year recurrence rates, so recurrence rates in the adjuvant setting is about 40% in the high risk, so that's a T4 and or N2 stage 3 tumor. And I think what they're looking at in this particular study was the disease-free survival if you gave neoadjuvant immunotherapy. So it was non-metastatic DMMR colorectal cancer. We're treated with 1 dose of IPI because it's toxic and gross. And no, sorry, I should clarify. It does work, but some people respond really badly to IPI. It's a bit of a hard drug to manage.
It can be gross, though.
Can be gross. Not everyone is gross. We could just edit that. And two doses of nivolumab and underwent surgery within 6 weeks of registration. So the co-primary endpoints were safety and 3-year DFS, and the secondary endpoint was major pathological response and complete response. This might sound familiar because a lot of studies are using a very similar design. So 112 patients were treated. There were minimal toxicities. It was really well tolerated. Baseline radiological assessment showed 89% of patients having stage 3, 77% having high risk stage 3, and 64% having T4 tumors. So median time to first dose of to surgery was 5 weeks, and pathological response. This is the result, guys. So pathological response was observed in 99% of patients, consisting of 102 out of 107 having a major pathological response, and 4 having a partial response. And pathological complete response, so like no viable tumor, that's usually what it means, was seen in 67% of patients. And a median follow-up at 13 months, none of the patients had disease recurrence. This is the point, Michael, that we spoke about. We spoke last week about the waterfall plot.
Yes.
Right?
Yes.
And you're like, that's not a waterfall plot. This is a waterfall plot. So I encourage all of our listeners to have a look because it is just a beautiful waterfall plot.
It really is, and this is a standing ovation worthy study, without a doubt. I admit that I let my Australianness get the better of me when composing that tweet using my Crocodile Dundee, but it really is incredible. And I think the interesting thing about this is that there are a lot of people saying, and I think this relates to what you said, Josh, about the lack of recurrence after patients who had a complete or major pathological response. We're potentially saving these people from surgery. So it's not like breast cancer where you do the surgery anyway to confirm a pathological response. You give the immunotherapy, you rescan them, you confirm that there has been, or you do another scope, you confirm that there's been a macroscopic major pathological response, and then you just watch them. So you're saving these people potentially significant morbidity through surgery.
Potentially, Michael, but I thought they all followed up with surgery anyway in this particular cohort.
Yeah, no, I think in the trial they did, but there was a question because it's not.
Okay.
It is comparatively, and I used the word comparatively very carefully because breast surgery can be incredibly morbid, but it is comparatively more morbid to take out someone's bowel then excise or even remove someone's breast.
Okay,
So
I'm on the same page as you. I was like, Michael, they're not suggesting that you don't operate on these patients. I don't think we have that data just yet.
no. This was people sort of throwing out their opinions about how significant niche 2 could be in terms of saving people from surgery up front.
I think I would be a little bit more hesitant to jump to that conclusion. I just feel we need much bigger trials to even suggest this. Plus, my other reservation is, once again, this is a DMMR population, so we knew they were likely to respond to treatment. I would love to see some neoadjuvant trials that kind of with colorectal cancer, or just using other agents, so we find another targetable or something that works for these guys, because we need more options. All right, I'm going to move to my final study. We're racing through this, Mikey, and I think we're doing a good job.
We're doing a great job, Josh.
Yes, great. So next is FRESCO-2, FRESCO-2, which is fruquintinib versus BSC, best supportive care. So this was a global phase 3 multi-regional clinical trial evaluating the efficacy and safety of fruquintinib in patients with refractory metastatic colorectal cancer. We're on the same topic, everyone. So background, we know there's limited number of treatments. The later lines of treatment aren't great. They're a bit challenging for the patient. They're myelosuppressed. They're frail. It doesn't go that well, and you have to kind of look for trials. So fruquintinib is a highly selective, potent oral tyrosine kinase inhibitor to VEGF1, 2, and 3, and was approved in China, I believe, in a metastatic colorectal setting, a cancer setting, based on the results from the, I'm assuming, the original FRESCO trial. So FRESCO-2 is looking at F, I'm going to just label it as F, in more heavily pretreated patients, reflecting current global practices. So the method, it was done lots of countries, lots of places, including Australia. And they were randomized to P, which is placebo, plus best supportive care, or fruquintinib, or F, I should just say, plus just F, right? And it's an oral tablet in a 28-day cycle. So the key criteria: had to have previous treatment, anti-VEGF therapy, and I want to know what the RAS wild type was as well. The patients were randomized to receive 2-to-1, so either the intervention arm or the control arm, and were stratified according to prior therapy, RAS status, and metastatic disease, time frame less than or more than 18 months, with the primary endpoint being overall survival and the secondary endpoint being progression-free survival. Mikey, I'm going to stop here. Why do you think they made the primary endpoint overall survival?
Because they had enough events, or they were expecting enough mortality events, that they could actually report overall survival fairly quickly, given that they're comparing it to best supportive care.
Yeah, exactly. So it's compared to best supportive care. So anything that's going to do anything will be better than nothing, right? Okay. Overall survival, 7.4 months versus 4.8 months. Hazard ratio of 0.66 with statistical significance. And PFS was 3.7 versus 1.8 months, with a hazard ratio of 0.32 and P of less than 0.01. Median duration of follow-up was 11.3 months approximately for both groups. And subsequent anti-cancer therapies were in about a third of each cohort. Now, what I found is that the greater than 3 grade adverse events was in 62% of the F cohort and 0.5% of the placebo cohort. They've actually put a table here, and I haven't really spoken about it, but they've compared the safety profile of fruquintinib to regorafenib to Lonsurf, which I hate pronouncing, but it's trifluridine and tipiracil, right? And the toxicity profile, when you're looking at numbers to numbers, are actually somewhat similar to regorafenib. Mikey, have you used much regorafenib in your practice?
My practice? Absolutely none, if I'm honest.
Yeah, I've suggested it about twice, if I must admit, and the response from a lot of my specialists I work with is that it's pretty hard to tolerate, especially in where the line of therapy is, which is later lines of therapy. And there's a small cohort of patients that are even going to be able to tolerate this as well. So, while yes, it does have a meaningful overall survival, um, and they said it was well tolerated. I'm not sure what you define as well tolerated, but maybe people, despite that, they could still live their life and do what they wanted to do. I guess the question is now, could you use this at that point? Can you move it up? If it is a really good VEGF inhibitor, could we then move it into an earlier line of therapy and kind of replace the existing one? That would be something that I would find really interesting compared to kind of standard of care VEGF inhibitors in the metastatic setting.
This is sort of how most new agents tend to develop, isn't it? They start at the bottom and then they show consistent benefit over things that have come before, in this case, best supportive care. And that's how they get sort of to the top of the tree.
Yeah, so it's potentially promising. I would be a little bit worried about the toxicity profile in the later lines of therapy, because if it's that versus going on a trial, I don't know. I need some experience with this drug to really see what we need to look at. But they say there's quite a bit of fatigue. I think most is probably mild, grade 1 to 2, but decreased appetite, diarrhea in, I think, 21% of patients, nausea in 17% of patients, fatigue in 42% of patients. I think that most of my patients who have later stage colorectal cancer are already pretty fatigued.
And you raise a very important point, Josh, which is, in general, the more lines of therapy you have had, the less likely you are to tolerate further therapy. Now, there's exceptions to this, and the exceptions are probably the majority of patients who made it to this trial, because I'm guessing they still had to be good functionally to actually be enrolled. But generally speaking, the longer you are on anti-cancer treatment for metastatic cancer of any kind, the more fragile you become and the easier it is for toxicities related to treatment to become overwhelming. And I think that's a very important point you make, Josh, because it can be applied really to almost any oncological situation.
Yeah, exactly. So this is not a magic bullet, but potentially it is something in our arsenal, and there would definitely be a subset of patients who would benefit from this. And an extra 3 months, as I so often say, means getting to that family event that someone really wanted to. Mikey, I'm aware of the time, and I want to make sure that you get to indulge us with all of your wonderful stories. So how about we switch over?
Sounds good, Josh. Sounds good. So much like Josh did last week, I'm going to be doing a fairly rapid run through of a few other areas that were covered in ESMO. And I'm going to start with genitourinary cancer. There didn't seem to be, at least from the other side of the world, following on Twitter and what have you, there didn't seem to be too much in the way of huge trials in genitourinary cancer as there were with lung and, as we've heard today, colorectal. But there are still a few tidbits that I'd like to talk about. And I'll aim to do these very quickly. The first trial is the Radicals HD trial. And this is a trial that I found quite interesting because it's something that I don't have too much experience with, and I'm not sure if it's the same with you, Josh. But it's about the duration of androgen deprivation therapy after radical prostatectomy in combination with radiotherapy. So it's early stage prostate cancer, which generally speaking is not something we see a lot of.
No, we don't. I had a couple of these patients, and yeah, it's always one of those questions. It's like, what do you give? Because we're saying, what do you give after radiotherapy? Is that kind of what this trial is looking at?
Or sort of with radiotherapy. So radiotherapy, obviously, as completion to or an adjuvant to radical prostatectomy, and then you're giving ADT on top of that, and the question is how much and for how long?
I'm going to guess 2 years, but enlighten me.
Not too far off, if we're honest. So patients were randomized to receive either no ADT, nothing at all, 6 months of ADT, which was called the short group, or 24 months of ADT, which was the long group. So, Josh, rather than being close, you're actually 100% on the money. And I'm guessing that's because you pre-read the study.
I can neither confirm or deny that I knew this fact.
Okay. It's good that Josh is doing the pre-reading. The primary outcome was metastasis-free survival, and the secondary outcomes were the time to salvage ADT, so at the time of recurrence or development of metastatic disease where you would normally start ADT, and overall survival. Now, this is a huge study that's actually been cooking for quite a long time. They recruited 2,800 patients, and they only finished recruitment in 2015. So this will give you a sense, Josh, of how long a duration of follow-up and survival we're going to be talking about.
I'm excited. I can't wait. Just hit it. Throw it at me. Tell me the results.
I'm going to throw it at you. I throw it at you literally if you weren't on the other side of a computer screen. So the median follow-up was 9 years, which is something that we really don't see in oncology research at all. The 6-month ADT group compared to the no ADT group did not improve metastasis-free survival or overall survival. The hazard ratio was 0.89. It did not meet statistical significance, and the metastasis-free survival at 10 years, you're going to love this, Josh, was 79 versus 80%.
Wait, say that again.
So at 10 years,
yep,
in the groups that had no ADT and the groups that had 6 months of ADT, the metastasis-free survival was 79 and 80% respectively.
So what you're saying, they were literally getting like lolly injections.
So pretty much for all of the good that it did, but for 6 months only. So they got a course of 6 months and then stopped.
So that's what I was implying with the lolly injections, but just
yes, yeah, exactly,
useless.
Yeah. So the 24-month ADT group did have an improved outcome compared to the 6 months, and the reason these numbers are numerically different is they did have separate comparator groups. So they had a subsection of the 6-month group that was compared with the no ADT group, and the subsection of the 6-month group that was compared with the 24-month ADT group. It's very complex and confusing, but that's the reason that these numbers are different. So the median metastasis-free survival had a hazard ratio of 0.77 with 72 and 78% EFS at 10 years. So that's event-free survival, by the way. So we're still looking at more than 3/4 of patients being metastasis-free at 10 years. The time to salvage ADT was improved with a hazard ratio of 0.73, but overall survival was not improved. And I guess when you're looking at these sorts of numbers, this sort of duration of response, bearing in mind that the median age of this study was 66, so statistically, I guess, or at a population level, when you're getting to 10 years, you're getting to patients who are 76 years old. They're probably, if they're not going to die of their cancer, they're going to have other comorbidities that might claim them. So it's not really surprising that overall survival was not improved. The question I guess this raises is, will we start seeing earlier referrals from our urology colleagues? Or, I mean, most of the urologists that I've worked with are very happy to start ADT. And so will we be seeing more people who have been on ADT for 24 months already before they actually get referred to us with castration-resistant disease?
That's a good question. I suspect that if they're going to progress from surgery or their definitive treatment to or radiotherapy to, let's say, castrate resistance in 2 years in that setting, I think there's other questions at hand, because A, were they the appropriate candidate that got this definitive treatment? Because it means it's pretty aggressive. Most of our patients who have definitive treatment won't go from castrate sensitive to castrate resistant in 2 years. But it is an interesting question about starting this treatment early And if there's no overall survival and guys have been followed up for almost 10 years, is it something that's we're worthwhile holding on to until they do develop metastatic disease? Because then if you've got hormone sensitive, so castrate sensitive metastatic hormone disease, and you start them on Thermagon or Degaralex or whatever it is you want to start them on, and you give them another 5 years at the age of 76, that gets them to 81. Then they have castrate-resistant disease, and they're still good. So you're like, cool, let's switch you to abiraterone or enzalutamide or darolutamide or whichever other one you want to give. That gives them another 2 years. You're 83. At that point, you can switch some things up. Lutetium's coming on board. There's actinium as well. So you've got other options. So, Mikey, sorry, I went on a tangent. I quite enjoy prostate cancer, at least the discussion part.
Yeah.
What do you think?
Well, I guess the main thing is that the patients received 24 months, so 2 years of treatment, but presumably were then disease-free or metastasis-free for 8 years or thereabouts without any treatment. So I guess at that point, if they do recur after 10 years, so 8 years after they've completed their treatment, you could theoretically say, well, they didn't progress on ADT, and then put them on ADT and then see if they are actually castration resistant, because they might not be, because theoretically their hormone levels would have been normal for the last 8 years.
Yeah, look, theoretically you are right. So, I mean, maybe they just last another 5 years at that point, and you've kind of just given them that 8 years. So, I think it's whichever way you want to look at it. I think it's potentially we need another 10 years of this study to really give us a good answer. That's a terrible cop-out, isn't it?
That's a cop-out among cop-outs. I guess the thing you did mention it though, that with ADT, with the evidence that the novel anti-androgens are better at the first line, we've got docetaxel in the first line with hormone-sensitive prostate cancer, we are fairly good at treating it in a lot of settings. The patients who go from hormone-sensitive to castration resistant after definitive treatment within 2 years are already poor players. You would be justified in treating them fairly aggressively. But at the same time, it's worth remembering that people who receive ADT can sometimes have significant side effects, particularly if they have a cardiovascular history, because there is evidence that ADT increases your risk of cardiac events due to sort of testosterone depletion and its effects on vasculature. So if you have a patient in front of you who has had a radical prostatectomy, they've had radiotherapy, and they have a significant cardiac history or significant cardiac risk factors, they're diabetic, they've got a family history, they've already had a triple bypass at age 66, maybe ADT is not the best idea for 24 months. And if you're not going to give it for 24 months, as this study suggests, you may as well not give it at all in this particular setting.
I'd agree with you, I think, because in that cohort of patients, if they never relapse, you're scot-free, and if they relapse 10 years down the track, you've got 10 years of not really aggravating a cardiac event that could be fatal.
Yeah, exactly. So I think I agree with you. I think this is still a little bit unclear, and as we said at the top, it's probably not something that it's not a decision that we will necessarily be involved with very much as oncologists, but it's worth being abreast of changes because these patients will inevitably find their way towards us. Moving right along, the next study to talk about is a renal cell study, one of two that I've got in the GU space, which is Cosmic 313. It's a phase 3 study of cabozantinib plus ipi-nivo versus ipi-nivo alone. And patients enrolled in the study had previously untreated advanced clear cell renal cell cancer, the most common type, and their IMDC risk was intermediate or poor. I won't go into the details of the IMDC classification system. If any of our listeners are unsure, I thoroughly recommend downloading the MedCalc app and having a look. It's basically a tool that we use frequently to try and assess the survival, or the prognosis, I should say, of patients with renal cell cancer. Quite a large study, Cosmic 313, with 855 patients enrolled, and the treatment was continued until loss of clinical benefit or intolerable toxicity. And crossover was not allowed, which I guess sort of practically makes sense, because if you progress on Ipi/Nivo, then adding cabozantinib on top of Ipi/Nivo probably isn't going to get you the best outcomes. You need to completely switch it up. Primary endpoint was progression-free survival, and the secondary endpoint was overall survival, which I will say right at the top was immature, the data for overall survival, so won't be talking about that. In terms of results, the progression-free survival, the hazard ratio was 0.73 in the intention-to-treat population, the overall population, and the secondary endpoints of overall response rate and disease control rate were numerically higher, but still unsure as to the significance of that. The toxicity, as one would expect, was significantly higher in the cabozantinib group, with diarrhea, rash, LFT derangement, and hand-foot syndrome all much more common in the triplet. And it's at this stage, Josh, that I probably should disclose a bias that I have to this study.
You're being funded?
I'm a shill. I'm a shill for the cosmic industry. No, the bias I have is that when I was but a wee lad in my first year of training, I actually saw a patient who had been enrolled in Cosmic, and he had got the triplet. And he had quite possibly the most horrific toxicity I have ever seen in my life, and I don't think I'll ever forget about it. He had hepatotoxicity, he had hepatitis requiring multiple immunosuppressive agents, including tacrolimus. He had nephritis and was dialysis dependent, and he also had immune-mediated bone marrow failure and was transfusion dependent. So he was really, really hit hard by this treatment. And so I must declare that when I heard about this and read the results of Cosmic, I immediately flashed back to this gentleman, and I thought, I'm not sure that's something that I would ever use. But that is a bias that I must bear. Authors also did a unplanned comparison between the efficacy in the intermediate and poor risk groups, so patients that are, I guess, better or worse, or have a worse prognosis. And the interesting thing, and the other thing that I think sort of makes me a little bit hesitant to adopt this triplet therapy, is that the efficacy appeared to be entirely in the intermediate group as opposed to the poor risk group. So there was no difference in the PFS and overall response rate in the poor risk group between the doublet and the triplet, but the PFS and the overall response rate in the intermediate group, the PFS in the intermediate group was 0.63. So the overall hazard ratio of 0.73 is clearly being driven by the intermediate group. And I'm not really convinced that the toxicity associated with a triplet, with the lack of benefit of in the poor risk group, makes this regimen worth it, given that Ipi/Nivo is already an excellent regimen.
I agree with you. Actually, it's a very, I think it's a difficult thing to talk to your patient and convince them to have triplet therapy with such a terrible toxicity profile and without any real known benefit. What I do love is I've looked up the publication page, and this is the line when it comes to the toxicities that they have used. The safety profile observed in this trial was reflective of the known safety profile for each single agent, as well as the combination regimens used in this study. The wording of that is just...
That's almost poetic in its vagueness.
I know. It's like, yes, every drug has a toxicity profile, but when you put them together, it's probably more.
Yeah, and it is cumulative. So, and look, under no circumstances are we suggesting that every patient will have the sort of toxicity that this one patient that I met did have. That's obviously not the case. Otherwise, it wouldn't have made the combination wouldn't have made it to trial or wouldn't have made it this far. But it is a significant factor when you're counseling and when you're talking to these patients about the relative pros and cons of Ipi/Nivo by itself, where the toxicity is already potentially significant, plus adding cabozantinib, and we know that cabozantinib has its own set of problems. And I guess if you're really bearing down on what that wording, that sentence that you just read, Josh, it is that, yes, you have three potentially very toxic regimens and you're giving them together. so that the toxicity can be terrible.
I think what I take from this, there's probably going to be a subset of patients who could potentially benefit from this. I think before we say no for everyone, we always have to think that giving these drugs, it's not a harmless proposition. People die. If there isn't a huge benefit or enough of a benefit, then we really need to think about it. Look, I talk to my patients about tamoxifen and the adjuvant setting of breast cancer. I know this is different, and when I tell them there is a very small risk of clotting and there is a very small risk of, endometrial cancer, right? And they look at me mortified. And look, it's tiny. Like, this risk is very, very small.
Less than 1%.
Exactly. And that's what I tell them. But, to these people, it's huge. And yes, it's in the adjuvant setting. So I appreciate that. And these guys, if they've got a couple of years left and you reduce that because of the toxicity, you need to think long and hard about whether or not the triplet therapy would actually be beneficial.
Yeah, absolutely. So I think we're a bit cooler on Cosmic at Oncology for the Inquisitive Mind than other people. But anyway, we'll move it right along. And the last GU trial that I want to talk about is Keynote B61, which is not a type of bomber used by the United States. It is a study of non-clear cell RCC. Now, non-clear cell RCC very quickly accounts for about 25 to 35% of all renal cell cancers, but they are notorious for the dearth of evidence behind the treatment. So we just sort of extrapolate data from the clear cell space, and there are a few sort of small phase 2 trials, but because they're less common, they're harder to recruit, and they're also a heterogeneous group. So the most common subtypes of non-clear cell RCC are papillary, which is the most common, chromophobe, medullary, and translocational. And translocational can be significantly nasty in that it frequently affects young people as well. Keynote B61 is a single-arm phase 2 study, so again another small study evaluating pembrolizumab plus lenvatinib as a first-line treatment of this heterogeneous group of cancers. The primary endpoint is overall response rate, and the secondary endpoints are duration of response, disease control rate, progression-free and overall survival, and safety. And results were only analysed in patients who received greater than or equal to 24 weeks of treatment. So patients had to be established on treatment before their results were actually analysed. So in terms of the breakdown of the patients, the most common subtype of non-clear cell carcinoma, as is the case in the general population, is papillary with almost 60%. Chromophobe RCC was next with 17%. The unclassified, it's also important to note that you can have sort of small bits and pieces, portions of different types of cancers. So unclassified was 12 or 13%, translocational was 4%, and medullary was 0.7%. The median follow-up was 8.2 months. And in terms of the results, the overall response rate for the whole cohort was 47%. But this was probably largely driven by the 53% overall response rate in the papillary cancers. Chromophobe RCCs had a 13% response rate, so really not responding very well. But the unclassifieds, by contrast, responded 71% of the time. The translocational group had a 60% response rate, but they only accounted for 4% of all patients. The disease control rate overall was almost 80%, again, largely driven by the papillary and undifferentiated patients. The 6-month progression-free survival was 72.3 months, and the 6-month overall survival was 87%. Common treatment-related adverse events are fairly typical for lenvatinib and pembro: hypertension, diarrhea, and hypothyroidism. And grade 3 to 4 treatment-related adverse events were observed in almost 35% of patients. Again, another small trial of a poorly studied and very difficult to treat set of cancers, but it is following in other studies in this area. There was another phase 2 trial that wasn't presented at ESMO, but examined the efficacy of cabozantinib and nivolumab. And so this combination of TKI and single-agent immunotherapy is, I guess, gaining traction as a potential treatment modality for non-clear cell renal cell cancer, which will be really good because these people are very difficult to treat.
Yeah, I agree, Michael. I think it's just having a look at the results here as well. One thing I would like to highlight, I'm pretty sure there's an Australian researcher in here. Howard Gurney is one of the head clinical trialists out of Macquarie University. For those who are not from Australia listening to our podcast, that's based in Sydney. I think it's a relatively largish research centre, so that's pretty cool, seeing someone from home turf being included in the phase 2 Keynote B61 study.
You just got to give a shout out to the local heroes, don't you, Joe?
I mean, he doesn't know me personally, but I recognise his name.
He will after this podcast. He'll be like, that guy gave me a shout out. I'll give him a job.
So yeah, sure, that sounds good. I appreciate your confidence in our podcast.
If we're getting jobs off the basis of the podcast, then a lot of far more qualified people are being neglected. Anyway, that wraps up my GU section. I have but 2 more studies that I want to talk about, and then we'll wrap this up because I know we've been yammering on for a while, as we always do. So the last section I'm going to talk about is skin cancers. And the reason I say skin and not melanoma is I've got a melanoma study and I've got a cutaneous SCC study. Now, cutaneous SCC is something that I didn't have too much experience with up until this year, but it is an area that we're becoming more and more involved with, and that's because of Cemiplimab, which is a PD-1 inhibitor. Acts much like any other immunotherapy, but there is very strong data that it has an effect in patients with metastatic unresectable cutaneous squamous cell cancers. And Josh, have you seen many patients with problems with cutaneous squamous cell cancers of the skin, which I guess is a tautology?
I've treated a couple of people with Cemiplimab, yes.
Yeah, it's really, really awful, especially when they get non-resectable. It's often affecting the face or other sun-touched areas, and it is the morbidity associated with these is frequently quite significant.
Well, you get half your face eventually cut out, and I met one guy who, as a teenager, his acne was treated with radiotherapy, and surprise, surprise, the outcome 60 years later was that he was getting terrible skin cancers.
The other group of people who also get these are patients who have transplants and are on immunosuppression from transplants. That's notorious for just recurrent refractory squamous cell cancers. And then, of course, Cemiplimab and things like that becomes a real dicey situation because they're immunosuppressed and you don't want them to lose their transplant organ.
Of course. So, Marky, what is what's the culprit when it comes to immunosuppressive agents that causes skin cancers?
Oh, that's a good question, Josh. I'm going to take a punt and say tacrolimus because that's the one I know.
I'm pretty sure it is. Back from our physician days where you had to hammer those 12 toxicities. Anyway, it's been a long time. I'll let you.
It has been a long time. Anyway, so Cemiplimab at the moment, what I was getting at before we went on a trip down memory lane there, is that Cemiplimab is used in the unresectable, locally advanced setting, so when patients are frequently refractory to radiotherapy and surgical approaches. This study, though, is actually looking at Cemiplimab in the neoadjuvant setting. So Josh mentioned this with his niche 2 analysis, but there's a significant push, and I think we've said this in previous podcasts, towards putting treatment even before surgery. So we're bringing treatment forward, we're bringing agents forward, and now we're reaching sort of the logical extreme of that, which is bringing them even before surgery. I think the only way we could escalate that is to put these things in the drinking water. But so the trial was looking at Cemiplimab neoadjuvantly in patients with resectable stage 2 to stage 4 cutaneous SCC. It's a multi-center phase 2 single-arm trial, and patients received Cemiplimab every 3 weeks for up to 4 doses, and the primary endpoint was independently assessed pathological complete response. Secondary endpoints was the rate of major pathological response, which was defined as less than or equal to 10% of viable tumour in the surgical specimen, and overall response rate. Small study with 79 patients enrolled. 62 patients, I should say, received all 4 doses, and 70 of those patients underwent surgery. The primary endpoint was met with a pathological complete response rate observed in 50% of patients, which is huge if you think about the morbidity, as we were saying, associated with the surgery. Major pathological response was observed in an additional 12%. So overall, you're looking at 63% of patients treated with neoadjuvant Cemiplimab who have a significant shrinkage and then a significant reduction in the morbidity of their surgery with neoadjuvant Cemiplimab.
That is a glass half full, Michael.
I like to be glass half full sometimes. It's exhausting to be depressing all the time.
And that's why you chose oncology. But look, that's great. They're going to do like longitudinal follow-up with these guys to see what happens.
I would imagine so. I would imagine that there would be overall survival data potentially there will be overall survival data. I didn't see confirmation of that. But I guess this is also opening the door to larger phase 3 studies where they can look at overall survival, they can look at recurrence-free survival. This is much more of a confirmatory open label study.
Cool.
Indeed. So cool, dude. We're about 10 episodes in and we're already devolving into the Ninja Turtles, so there you go. In terms of safety, 17.7% of patients experienced a grade 3 or grade 4 adverse event. 4 patients experienced grade 5 adverse events, but these didn't really seem to be immune mediated. So they actually, because there was only 4 patients, they could actually state what the reasons for the grade 5 toxicity, which is a fatal toxicity, as we've said, was. So 1 had an exacerbation of pre-existing CCF, 2 had ischemic heart events that were fatal, and 1 had COVID-19 pneumonia. So none of those are really related to, or at least not directly related to, the Cemiplimab.
I'm going to say the COVID-19 was completely not related to Cemiplimab.
Yeah, I think that's a fair assessment. So basically, in summary, this is, again, it's entirely possible that we will start to see cutaneous SCC patients earlier on because, like I said, we do tend to see them when they're much more in the salvage end of the road type phase. But with neoadjuvant Cemiplimab, we might be seeing them earlier. And my final study, which is a study that is potentially of great importance, it's another neoadjuvant study, and it's a melanoma study of neoadjuvant pembrolizumab. This is SWOG 1801. And it is neoadjuvant pembrolizumab compared to adjuvant pembrolizumab in patients with stage 2B to stage 3 melanoma. So it included patients with cutaneous, acral, and mucosal melanoma, which I thought was very interesting because frequently in studies that I've seen, the non-cutaneous subtypes of melanoma are sometimes excluded. Obviously, there's none of the super rare things like uveal melanoma, but the inclusion of acral and mucosal melanoma is interesting. Patients were randomized 1-to-1, and they either received upfront surgery followed by adjuvant pembro for 18 cycles, or 3 doses of neoadjuvant pembro, went to surgery, and then had 15 doses of adjuvant pembro. So regardless, they're getting adjuvant pembro, but the question is whether it's worth sandwiching the surgery a little bit. Radiotherapy was allowed after surgery, and the primary endpoint was event-free survival. There were 313 patients in this study, so for a phase 2 study, it's pretty big, and the median follow-up was 14.7 months. Now, the event-free survival in the neoadjuvant group compared to the adjuvant group, the hazard ratio was 0.59, and the overall survival hazard ratio was 0.63. The benefit was consistent across age, sex, performance, status, stage, level of LDH, whether the original tumour was ulcerated, and the BRAF status. And so you have a significant improvement in recurrence rates, a 41% reduction in recurrence over the 14 months in patients who received just 3 cycles of neoadjuvant pembrolizumab. And I think what makes this especially exciting is we're not actually changing the treatment. We're not changing the amount of treatment that these patients are getting. They're still getting 18 cycles. It's just the sequencing. So it's a very, very easy change to make to practice. The same proportion of patients made it to surgery, and then subsequently to adjuvant pembrolizumab in both arms. So you're not impacting patients' ability to get to surgery or to get adjuvant treatment. And the adverse events were similar in both arms, as one would expect, because again, the amount of immunotherapy you're getting is the same. 21% of patients, lastly, were noted to have a pathological complete response on review of their resection. So really, this is potentially game-changing, and that's why I sort of left it to last. One of the most esteemed melanoma specialists in Australia, so a nation of melanoma specialists, Professor Georgina Long, tweeted after this was presented that this really should change the management almost immediately of earlier stage melanoma. So it is potentially practice changing, and it is something that should definitely be considered with, as far as I can see, Josh, very few drawbacks.
Yeah, look, I think melanoma is one of those diseases that can be one of those. It's a nuisance to treat because the recurrence rates are high. I guess for Australia, or for us specifically, it's not funded in the neoadjuvant setting. So I would love to see another trial, bigger trial, like them to kind of come to the government, wherever you are around the world, should promote this too. I don't know.
It's come to Australia. We've got melanoma for days for your melanoma trials.
We've got melanoma patients for days at high UV. So it's great. I think we need to do it. I kind of agree with Georgina Long. If you're going to reduce the risk of recurrence by that much at 14 months, I do want to see a longer follow-up. I really do. I think I'm always like, oh, we've got to discuss this, but I just want to be 100% certain in my mind that giving this neoadjuvantly is better. But if you've got the theme of ESMO over the last 2 sessions and all of these trials, and I think it's Checkmate, correct me if I'm wrong, but Checkmate 816, Michael, the lung?
816 for lung, yeah.
Like, it's all heading that way. It's heading that if we kill the cancer before we cut it out, we're going to improve outcomes.
Absolutely. And it's, like I said, it is the natural progression of, initially we cut the cancer out and then only treated it when we couldn't, with chemotherapy, when we couldn't cut the cancer out. And then we cut the cancer out and then gave adjuvant treatment. And now the natural progression of that is to treat first and then cut out and then actually be able to see what the result of the treatment was. So it is a very exciting time to be practicing oncology. We will be seeing patients a lot earlier with this push towards neoadjuvant treatment. And further to your point, Josh, about it not being funded, I suspect that Pembro will be funded very quickly for neoadjuvant treatment of melanoma, mainly because it's, like I said, it's not actually going to cost the government any more than it already is. All they need to do is just change the wording of the approval, but the government would be paying the same amount because the total course is the same. It's 18 cycles. So I think that this is one of those things that hopefully the government will look at and say, I mean, it's no skin off our backs, and if it's improving patient outcomes, then definitely should do it.
I would love to leave with one final question in this particular trial, Michael. So you give someone the 18 cycles of pembrolizumab in the neoadjuvant and adjuvant setting, and 2 years later they recur. What do you do?
Ipi-Nivo. Assuming they're BRAF negative, in which case you'd probably do encorafenib and binimetinib.
Yeah, which is,
But again, I think this comes down to something that we were sort of touched on earlier, which is with the prostate trial, which is that they have not progressed on treatment. So yes, while the possibility of treatment might be, the possibility of them having a dramatic treatment response might be low, then they haven't actually demonstrated failure of the treatment. Now, if you are giving them the immunotherapy, they get to cycle 15 or cycle 8 or cycle 2, and they already recur, then you're in big trouble because you have objective evidence that immunotherapy is not working.
I guess you are right in that respect, but I always worry. A little bit of me just worries. I'm like, if I'm going to re-challenge you with another immunotherapy, I want it to work. I want to know that we still have something to effectively melt that cancer away, especially melanoma. But you're right. We don't have that answer. They haven't failed from the treatment, but I suspect the way the biology works, that your immune system is stimulated, it adapts, it kills the cell. That shouldn't change. So if that does change and then they recur, it means that your immune system isn't able to maintain that process. But look, that's just me thinking in the future. But if it was me and I had the option of neoadjuvant pembro, I would take it, especially with these stats.
Definitely, and I think it's the eternal question, and we've had it. I know you and I have had it, Josh, sort of off the air, but the eternal question of, do you push all of your chips to the center of the table and put all of your treatment up front and say, we need to give you the best chance of nipping this in the bud, or do you hold things in reserve? And I think that it's a discussion with the patients, it's a discussion with the individual patient, but my default setting has increasingly become, if there is a chance to prevent a patient from recurring, then you've really got to take it. But that's just a personal opinion. Everyone will be different.
I would actually agree with you. I think you can't go home and sleep well at night if you've got an option and you've told them, let's wait and watch.
Exactly. And if we extrapolate data from other tumour streams, there does seem to be a mode of thinking that if you wait until the metastatic incurable setting, even if it's the same treatment, the treatment very well may be less effective for any number of reasons. But the you might find that even though you're giving the same treatment to the same patient, if you had given it up front, you might have had a numerically better outcome than if you held it back.
100%. I think the next line of treatment after neoadjuvant, this is my theory, you give a pill and they don't need surgery. The end.
Which would be great. It would be absolutely fantastic if we can save people from needing surgeries. If surgery becomes the salvage rather than chemotherapy. But that's a bit of a pie in the sky type thinking at the moment.
We would be the sexiest specialty alive.
Oh boy, wouldn't we just? I mean, all right. Well, we have gone well over our allotted time, I think, tonight, Josh. So we should wrap it up very quickly there. I guess if you're going to take one thing away from our 2 episodes of ESMO wrap-ups, it's that neoadjuvant treatment is here, and it's only going to get more and more important.
I concur to that statement.
I'm glad you concur to that statement.
Yeah, I'm excited for next year's ESMO, where hopefully you and I will both get to attend.
I know. We're going to have so many shenanigans. Anyway, so join us next week. We will be on back to our usual schedule of tackling a subject and trying to give the more in-depth analysis of 2 very pivotal studies. And next week, I think we are looking at metastatic urothelial cancer. So we really hope to see you then, have you listen then. If you like what you're listening to, find us on Twitter. And as Josh said, facetiously like, subscribe, leave a review, watch our TikTok. We don't have a TikTok. We're never going to reveal our TikTok. And we will see you next week for more oncology for the inquisitive mind.